I'm going to tell you about the future of everything, healthcare. Not because I have visions. Visions get you psychiatric referral or but this is the plan. I'm going to tell you the plan. And it's helpful to look back, and we're looking back and celebrating today. And I see us at the start of the third healthcare revolution. The first healthcare revolution was based on empiricism, not on science, really. This is an icon in the UK. This is the map of Soho, prepared by John Snow, long before bacteria were ever identified. And, of course, antisepsis and anesthesia were empirical developments. The second revolution has been the last 40 years, my time in medicine, and the second 40 years have been high-tech. They've been, and I've picked some surgical examples here, astonishing developments in the last 40 years, unthinkable developments, which have had as big an impact as the first revolution. But at the end of 40 years of progress, right-click, okay, thank you. At the end of 40 years of progress, every health service in the world faces these problems. Every health service in the world. Failure to prevent preventable disease. I'm not talking about smoking cessation, I'm talking about stroke and atrial fibrillation, for example. There's probably 20,000 strokes in the UK that could be prevented simply by getting AF organised. Inequity, patient harm, even when quality is high, and I'll come back to that. Waste of resources and unwanted variation in everything we look at. And coming up ahead, there's an iceberg. Need and demand will increase. In most countries, money will not increase. It'll be constant. In Italy already, there's been a reduction in the budget for healthcare of about a couple of %. And even where money is increasing in Brazil or in Saudi Arabia, the gap between need and demand on the one hand and money on the other is widening. The US, of course, is a special case. How many people here from the United States? Every time I think life is difficult, I look at healthcare in the US. But as a friend once said to me, just remember, we've nothing as bad as their worst and nothing as good as their best. And actually, a lot of the articles I've been reading the last few years about value have come from New England Journal and Annals and JAMA. So God bless you. God bless America. I've also put here the need to reduce carbon, and we have a carbon budget for hospitals. And actually, we have a Centre for Sustainable Healthcare in Oxford, and we're very keen to have a surgical project, because most carbon is not heating and lighting, it's staff and patient travel and drugs and equipment. So to reduce carbon, we need to think in different ways. We were speaking earlier about, do you admit people twice for cholecystectomy or once? Whatever the other benefits, there's also a carbon benefit. And frontline staff are often more motivated by carbon than by money. You say to the staff, look at this hospital's in financial difficulty, and the staff say, of course it is. Look at the idiots who are running it, who are usually standing beside me. But speak to them about sustainability, and the staff engage in a different way. So we need the third revolution, and the revolution is already underway, driven by three forces: citizens, knowledge, and this. How many of you don't have a smartphone? Yeah. There's always some in the middle class who don't have a smartphone. I'll tell you three things about smartphones. Poor people have them. Poor people sure as hell know how to use them. And you're all going to have one. It's been decided. Not by the government or anything like that, but next time you're going to change it, they'll say, oh, how quaint, you should put that in the Antiques Roadshow, but this is what you're going to have now. And of course, places like Africa, India, this is just standard means of communication. So this is the revolution. This is the century of the patient. And here's the paradigm. This is how things are changing. We're moving on. You see, from about 1950, the paradigm was that healthcare was free. 1972, Archie Cochrane published Effectiveness and Efficiency. It's 20 years now since we opened the Centre for Evidence-Based Medicine and the Cochrane collaboration in Oxford. And effectiveness morphing into evidence-based became the dominant paradigm. In the last 10 years, it's been quality and safety, driven largely by the Institute of Medicine's wonderful publications in the year 2000. So we take that for granted. We're going to move from competition to collaboration, from structural reorganisation. I've had 20 reorganisations, most of which have made no difference at all. Structure doesn't matter. Structure doesn't matter. Tax-based, insurance-based, co-payment, no co-payment, they all have these same 5 problems. So let's look at some of the aspects of this. Firstly, knowledge. We're in the knowledge business. And let's just separate particular knowledge about this patient or this hospital from generalisable knowledge. And generalisable knowledge I find useful to distinguish between tacit and explicit. And explicit knowledge are of 3 types. Knowledge derived from research, we call evidence. Knowledge derived from the analysis of routine or audit data, we call stats or information. And knowledge from experience. So this is the journals largely in the knowledge from research business. But increasingly, we're looking at data, and we publish atlases of variation. They're modelled on the Dartmouth Atlas, published by the great Jack Venberg. And here's an example of variations in hysterectomy. And here's cruciate ligament repair. No orthopods in the audience, no, a 50-fold variation. So I've had some big run-ins with the surgeons in the last few years. When we started publishing these, we published reviews all the time of what different jurisdictions were doing about surgery. And Sir Bruce Keogh went to a meeting once, and there were surgical specialist societies, I think there were 9 of them, they were furious. And they said the Department of Health is banning operations. And Bruce Keogh said, no, we don't do that, the Department of Health. We never think of that. And then they said, they banged on the table a big document, so here's Muir Gray's list of banned operations. I produced examples of what different organisations were doing, which other payers had turned into a list. But I work on the principle that there's no difference between irritation and stimulation, apart from A, spelling, and B, irritation is more effective than stimulation. So I started meeting with surgical specialist societies. And when they said to me, we need more money for knee replacement, I said, well, wait a minute, what about this? And we need more money for hip replacement. I said, well, where did hip arthroscopy come from? Oh, it's a developing technology, as well as it being delivered in the context of a trial which would allow us to measure its value. No, it's just sort of creeping into practice. That's not sustainable in the value century, because the new paradigm is value. Now, value is subjective, and there are many different values. For industry, there's return on investment, for example. But I'm just going to speak about 2 aspects of value and how I would look much more for different types of articles appearing. I mean, the only pound sign I could see was the subscription in the subscription page of the journal. And interestingly, in the carbon, you see you're still charging the same for electronic only and paper only. Well, that doesn't sound very 21st century to me. But let's just focus on allocative efficiency. So here's what healthcare looks like. We've got programme budgeting in England. We're one of the few countries that have got it. It's pretty much similar in other countries. So respiratory is 5 billion, 4 billion, 7 billion. How much do you think we spend on mental health? I should vote. I'll give you 3 options: 1 to 4, 4 to 8, over 8. 1 to 4 billion. Hands up. 4 to 8 billion. Over 8 billion. Yeah, it's 11 billion. Not counting 5 billion worth of mental health problems in abdominal pain clinics and pelvic pain clinics and dizziness clinics and other places. So now the payers have to decide on the switch of resources between mental health and cancer, or vice versa. But there's the next level we're calling, within programme between system margin analysis, is the clinician's responsibility. Now here's this 4 billion here. And when I look at that 4 billion, which is about £80 million per million population, I started thinking this way: liver and gastro. Oh, we're hepatologists, we're a separate discipline. Well, but you're in the same programme budget. You are responsible. If I now had all the hepatology and gastrointestinal people in England in the room, I would say, well, you're responsible for this. What's the right balance between the two? What's the spend? And obesity, what about obesity? Where does that come from? Or is that an endocrine disease? Or but we have to be clear we're spending money on it. And when we get down to one level more, to within program between system margin analysis, then we see the need to look at the money that's being spent. Bariatric surgery, for example, had a hard time with the payers in England, but there's £100 million spent on orlistat, which isn't a very effective intervention. So I need you guys to help me switch that money, because if I start taking on orlistat by myself, that's not so easy. But if the surgeons say, yeah, it's higher value to switch money from one to the other, then that's a much easier sort of thing. But you're responsible. You are the stewards of the resource. Stewardship's an interesting word, which doesn't translate very well into other languages. The good steward leaves the farm in better condition than they find it. You don't just keep taking things out. And the clinicians as stewards, if we screw it up, then there won't be a health service like we know it. I was in Canada recently, and I was saying this in Canada too. Government, we just bring in insurance companies and McKinsey's or somebody, just like that. Australia, the same, these debates. So it's the leadership of the profession that's extremely important in this. Now, when we come on to a collaborative approach, this is the problem that we see in most countries. An archipelago of healthcare. General practice, family medicine, called in different things, 6 billion. Hospitals, 70 billion. Mental health, 11, and community service, about 30. And the occasional patient swimming from one to the other with great difficulty. I mean, mental health and physical health completely separate in most places, in spite of the huge overlap in the problems that people have. And this is the model that we're now developing here, and we're calling it population healthcare as opposed to institutional-based healthcare. And this is healthcare based on the either symptoms, such as breathlessness or headache, or pelvic pain or upper abdominal pain. Conditions, inflammatory bowel disease. I've been promising Neil for some time that we will sort out inflammatory bowel disease. Or characteristics like being frail and elderly, or being under 65 and having 2 physical conditions and substance abuse. There's about 30 businesses of that shape, and in each business there are systems. So within respiratory, you've got asthma, COPD, sleep apnea, and a lot of rare stuff. There's under 100 big problems, and the same in every country. Now, you see, for broken legs, things work very well. If you get run over out there and fracture your tibia, you don't need a good GP or the correct health beliefs. You'll get the right place. But most of healthcare is not like broken legs. And well, it looks to me, most of healthcare looks like Brownian motion, the random movement of patients, professionals, blood samples and reports. Not all of it. I wrote this actually in the Lancet in 1983 and said we should stop using, and at this stage, if I were working with you in England, I'd be saying that we now ban the use of the words primary, secondary, acute, community, hub and spoke, outpatients. Banned. 20th and 19th century language. And I wrote this in 83 and said we should run the whole of healthcare like this with budgets. I showed it to somebody last year, and then I showed him the date. He said 1983. Clever, you so clever. So I rushed to someone else and I showed him the date, and he said 1983. What the fuck have you been doing for 29 years? The answer, waiting for Lehman Brothers. Now, we've had some success, you see. If you look at how healthcare is organised, and you scroll it out of 0 to 100, to be able to ask and answer intelligent questions. Cancer is quite well organised, end-stage renal failure, and more recently acute MI, acute stroke, and Jonathan and I worked on screening. We set up the screening programmes. But screening was quite easy, because we're in a defined population and a degree of moral authority. And the results of the screening programme, not so much the screening itself, but the impact of moving to a population-based system I think it's the mortality dropped from 7.5% to 1.8% for elective operations. System. Toyota. And Toyota hates waste. There's a wonderful word. You know the word Muda? Kaizen is continuous improvement and Muda is waste. There's another fantastic Japanese word called motainai, which means a feeling of remorse for having wasted resources. I don't see much motainai in my So once you've got the system, then we start to move into issues that are going to come up increasingly in the next decade. This is classic Evidence on a beat in 1980. As you put more money into healthcare, the benefits increase and then they flatten off. The trouble with healthcare, what makes it a very difficult business, is this. The more healthcare you do, the more harm you do. This is not to do with safety or anything like that. This is high quality healthcare does harm. You know, we're giving people chemicals, radiation, operating on them, it's bound to do harm. And then if you put these graphs together, you get a J-shaped curve. So, once in a lifetime cervical smear, 10-year interval, 5-year interval, 3-year interval, 1-year interval. One artificial kidney in the population, 10 per million, 100 per million. I used to run the only artificial kidney in the northeast of Scotland when I was a senior house officer. The professor of surgery had the only artificial kidney in the northeast of Scotland. The only advice I got was, don't let those bloody physicians get their hands on my kidney. And the senior register and I ran it. And when he was in Shetland operating, I was in charge of the only artificial kidney in the northeast of Scotland. And we had a 100% success rate. Because we only dialyzed 35-year-old people with acute tubular necrosis. What's happening now? Chemotherapy in the last year of life. Intensive care in the last year of life. This is not about money. This is about the balance of good to harm. And the big debate in England is emerging is having a good death as well as a good life. And this raises issues about clinical decision making and the use of resources. But there is this issue now as we move into the value. Once you've made the allocative decision, they are now moving into different value propositions. Now, this is where population and personalised healthcare come together. So when we started the Centre for Evidence-Based Medicine, I recruited Dave Sackett from McMaster to a chair in clinical epidemiology, funded by our research and development programme. And then again, on the principle of irritation being more effective than stimulation, at the last moment I changed the name of the centre to the Centre for Evidence-Based Medicine, and it sure as hell irritated people. There was a very hostile leader in the Lancet in about 6 months' time. Who do these people in Oxford think they are? We are doing evidence-based medicine. So, we're accused of cookbook medicine. And maybe if we'd use a picture like this, rather than just words. There's an interesting issue about pictures. Wittgenstein said every idea is a picture. So this is the way we thought of decision-making. That it was certainly evidence-based in the study of groups, but it had to be related to the clinical condition of this patient, and this is the job of the clinician, because the evidence is never right for this patient who's got not only heart failure but a few other diseases as well, and to the values of this patient. Now, we're also seeing, of course, the genetic profile coming in. I do not think the human genome is a paradigm shifter. I mean, to me, the genetic, if I've got prostate cancer or something, it's another marker of some sort. It doesn't actually tell you or the patient what to do, but it does increase the amount of data involved in the decision. But this is personalised, and the jargon is stratified medicine. I've got my human genome done. My daughter wanted to, she did it, and she wanted to trace the family history. So I'm pleased to tell you I'm 2.9% Neanderthal. And I get 120 risk profiles, which I immediately clicked past when I got the report in for $79. So now the issue here, we published this in our second Atlas of Variation. As you put more resources in, the offer changes for the individual. So when you're only doing one cataract or 10 cataract operations per million population, you're operating people who are really blind, housebound. As you do more, you start to offer treatment to people who are less severely affected. And the same would apply to vascular surgery or whatever. You increase the capacity and the threshold changes. The problem is that in medicine, the probability of and magnitude of harm is the same, and the probability of benefit decreases. So if people my age, you go to the optometrist, oh, it's got a cataract there, cataract on the waiting list, have a cataract operation. But 1 in 1,000 go wrong in the best centre. That's why if you were all ophthalmologists or optometrists, what would you think as I did this? That bastard had his eyes tested. I bought these for £1, you see. Stay clear of having... I'm also going to market Muir Gray's anticubital photogars, so you can never have a blood sample taken that you don't really understand. So let's come on to the all population surgery. So these are the questions that bother me. And it's certainly very important to look at institutional quality and safety, but these are population questions which can't be answered for any condition, apart maybe from a few cancers in any country. These are, is care for people with pelvic pain better in Alberta or Saskatchewan? Is care better in Venetia or Lombardia or Wales or Scotland? We don't know these, and within country we don't know these. So these are population questions. Now, we've started, as part of population healthcare, we've been thinking about population surgery. So here's an example of a really good surgeon. Terrific. She does everything evidence-based, patient-centred, a lot. But Miss Jones, how many people are there with claudication in Barsetshire? And the answer is 1,000. So she puts a bid in, she does an audit, finds 100 would benefit from our service, puts a bid in for more resources. But in Miss Jones, there are two problems. One, there's no more money. And two, we've done away with the idea of outpatients. What we will do is, we'll like to tackle these sorts of problems. Why are some people getting to the vascular clinic and not others? So we'd like to run a population-based service, just 1 day a week. This is different from managing the service for the referred patients. And this is the sort of thing we'll be thinking about when I work with Neil on inflammatory bowel disease, which is also mixed up with irritable bowel syndrome, and maybe it's abdominal pain is the issue. We have two different programs, one a pain program, one once the diagnosis is made. So we want somebody to take responsibility to find out things like, well, how many GPs are there in Barsetshire? What do they believe about people who say they've got difficulty walking? This is a population responsibility. It's a different thing from medical management. And I'm just about to publish this little book, and I'm in discussion with a couple of young surgeons about turning to population surgery or population neurology. And we'll do it electronically. It will be expensive, and we'll put in examples in different ways. So here, this is paper, because paper is quite, I love paper, I buy lots of books, but we're just scaling it up. We'll do this electronically, and we'd love to do it with the Journal of Surgery. Okay, now we, just to finish, the issue is a change in culture. And this is, for the last 5 years, I've been very interested in culture. I suppose for the last 30, it's culture and language. Oxford's full of anthropologists and linguistic philosophers and historians. Numbers are important, but words change the world. So no point just publishing data showing variation. You have to get in there and persuade people to do it. So, and leadership and culture are intertwined. And you are the leadership of surgery. The BJS is part of the leadership, and I know there are other journals here, but this is leadership. And this is where we have to now move on to getting the clinicians to take responsibility for the stewardship of resources. Because people from a general management background have a part to play, but you have to understand what you're dealing with. This is a key issue of understanding what you do. So if you asked every surgeon in Oxford or England, or just to write down some simple things. Leadership has different aspects. Partly is sort of emotional, how you behave, how you speak, but it's also cognitive. And these are the sorts of cognitive issues, and so we've been developing a glossary of 21st century healthcare that could be adapted to a glossary of 21st century surgery. This is new language which the journal and all the journals could play a part in developing. And finally, back to this issue here about different types of knowledge. I think the type of knowledge that we are not harnessing is knowledge from experience. And I've started now in a number of places to introduce the idea of casebooks. So this is a public health casebook. And the public health casebook, the structure of the article is different. What was the problem? Why did we decide to tackle it? What did we do? Why did we do it that way? So there might be evidence coming in there. What happened? What did we learn? And is there any further information? And this should be, my own view is that everyone paid £100,000 a year must do one of these a year. I mean, if you work for Accenture or someone like that, you would have to submit. You would have to be trying to do something, as you all are, but you have to put it in. There's a wonderful, got a wonderful headline from the Singapore News about 10 years ago. Toyota is a knowledge business, not a car business, a knowledge business. Healthcare is a knowledge business, but we need to think of how we would use this type of knowledge to develop a surgical casebook. This is the entry. This is all designed using open source software plus. It cost me quite a bit to do, but it's all open source. You know, it's Koha library software at the back of it, and they're very simple. Sort of stuff you used to pay thousands of pounds for the software. So the future. The future is not like Iceland or Mount Everest waiting on arrival. The future is like the Forth Road Bridge. Something we imagine, design, plan and build. Something you imagine, plan and build. If you don't do it, other people will. Thank you very much.